always exciting for us to have a medical doctor, Dr. Kathryn Gill, and Hagopian, Dr. Michael Hagopian, and you work together in Santa Monica, and have been doing this for a very long time. And so welcome. It's really great to have you, Michael. Thank you for being here. This is our dedicated, very enthusiastic group. So you're in very good company. I feel that you're the same. And he's going to share a presentation, and go ahead. It's so nice to have you.
Wonderful. Hi, everyone. I'm Dr. Hagopian. Good to see you all here. What a group we have here. My goodness. All right, let's get into it.
Just you wait. No, I'm kidding. Honestly, we have such a fantastic group because everyone here is Saturday morning tuning in because they are passionate, they care, they bring these elements. Obviously, if you're in the other part of the world, the sun is setting. It's very international. And so yeah, I'm just
so great.
here. Yeah.
So today's talk by Dr. Gill and myself will be about how osteopathic medicine and myofunctional therapy work together collaboratively. We're going to get into a lot of different topics here. We had some great requests for topics, so I'll be going through some brief overviews. I'll give you an outline of where we're going to go and some of the relevant anatomy, physiology for a few of the most common complaints that were requested: anxiety, eustachian tube dysfunction, things like that. And then Dr. Gill is going to go into a lot of the clinical application and bring in her pearls from her 30 years of practice here. Okay, so I think everyone here is very familiar with why mouth breathing is problematic and some of the complications that can happen both in the pediatric population and adult population. So I won't belabor that, but I will give you guys an overview of some of the subject matter. First, we're going to touch on tinnitus as well as eustachian tube dysfunction, and then move into temporomandibular disorder. And then in part two, we'll go into sleep disordered breathing and also a little bit of anxiety and how this works with orthodontics. In parts 3 and 4, we can save for another time. If you guys like what you have learned today and how we present to you all, then we can do some more presentations in the future. But in the interest of time, we'll keep it at those topics. So with tinnitus, this is generally thought of as a ringing in the ear, but it can be any sound that is present in the ear. Sometimes it's a whooshing, a vibration, a fluttering sound. It generally is there most of the time, comes and goes. But because of how related the cochlea, middle ear, and even some muscles that have to do with the jaw and mastication, we have a lot that we can do for these patients. Most of them end up at an ENT's office, and the ENT will check for hearing loss, send to audiology for hearing aids, and sometimes it works, but if it doesn't, then they do cognitive behavioral therapy, and that's pretty much the only major options there. So that's where we come in, and I will explain some of the relevant anatomy. I don't want to get too deep into the weeds of all of the cranial nerves, but feel free to screenshot my slides. Dr. Gill's slides have a little bit more HIPAA protected and private pictures, but if you guys want to screenshot the pathways or some of the anatomy there, that's totally fine with me. So tinnitus is prevalent in between 25 to even 80% of the population, or 10 to 31% of the population, but there's an overlap with TMJ patients. So that should tell you a lot about how much the temporomandibular joint has to do with hearing and auditory processing. And that's because of these 5 cranial nerves that all overlap in this disease process. 7, 5, what else? 8, of course, for hearing, 9, glossopharyngeal, and 10, the vagus. The eardrum itself actually is innervated by 3 different cranial nerves when it comes to its sensory input. So how does this work? Really, there's a disinhibition of some nerve pathways. That means the ability to turn off is lost. That's what disinhibition is here. So we see a central desensitization, kind of like chronic pain. When someone has a pain in the arm that's going on for so long and it gets centralized, the spinal cord just learns to sense pain, and that becomes centralized. They can end up with pain in other areas that have no structural abnormality. And that's a very similar process to the central sensitization that's happening here in tinnitus. So what can we do about it? In osteopathy, because of how related this area is to the jaw, we can treat intraorally, we can treat the jaw. I'll go into some of the techniques here that just to give you guys some overviews. I want people to come away from this talk with an ability to know what we do in an osteopathic office and how to talk to their patients about it too. So we can do techniques such as the temporal bone rotation and treating the articulations with other bones in the skull. This is really important because cranial nerves don't just pass through the actual temporal bone itself, but in between the temporal bone and its related bones. So in between the temporal bone and the occipital bone, the vagus nerve traverses through. So any kind of compression between those two will lead to pathways and signals not going back and forth. It's like the cable is being squeezed on. I want to teach everyone one osteopathic technique that's very parent friendly. And I'll do that when we talk a little bit more about eustachian tube dysfunction. But just to tease into it, it's called the Galbraith technique. I wonder if anyone's familiar with that. But it's very useful for ear infections or just fluid in the ear. And it's also helpful sometimes in tinnitus. So let's do it. Basically, I show the parents by actually placing my finger on their thumb and showing them how gentle I'm being. But what we want to do is take two fingers, you guys can do this with me, and hook behind the angle of the mandible. And we're going to be drawing the jaw directly towards the patient's chin. So from this side, picture an arrow, a vector going from the angle of the mandible to the patient's chin, and it's just gentle pulling with an unclenched jaw. The teeth are separated, and we're just doing that 5 to 10 times. And that's stretching and elongating the eustachian tube. And of course, we want to do it on the side that's affected, whether it's a tinnitus media, an ear infection, or tinnitus on that side. But we don't want to leave patients crooked, so I tell parents, do the other side too. And it's super gentle. We're not dislocating anything. We're just essentially milking the eustachian tube. So that's a helpful one. I give that one to parents for maintenance. I usually tell them, wait 48 hours after a treatment before you start doing something like that. Let the treatment set in. But it's nice to send them home with things that they can do themselves that are free. Okay, so with myofunctional therapy support, by retraining muscles like tensor tympani and the pterygoid muscles, also the muscles of mastication, that can affect the whole TMJ complex. Also, working on tongue posture is really important for nasal breathing. And if we can reduce the overall hypertonicity of the muscles of mastication and that resting tone, we can reduce the amount of compression that's being driven through the TMJ into the temporal bone at baseline. So we need multimodal approaches for something as complicated as tinnitus, and that's why these two together can be so beneficial, myofunctional therapy and osteopathy. Moving on to eustachian tube dysfunction. So the eustachian tube, everyone knows here, connecting from the middle ear, which is an open cavity, supposed to be filled with air, and that connects to the nasopharynx, the back of the nose. Key muscles include the tensor and levator veli palatini, and this helps to regulate tympanic membrane pressure because this tube is very compressible. Think of one of these paper straws that don't hold up in your cup for longer than 5 minutes. It's about that collapsible. It doesn't have any cartilage around it to support it, so it relies on these muscles and jaw movement, proper jaw movement to stay patent, open, and draining. Normally, it's supposed to equalize the pressure in the ear. When pressure outside the head changes, it protects the ear, it drains the ear, it ventilates the ear. Anywhere in the body that does not have proper blood flow to and from and adequate drainage is a nidus for infection. And that's why we see otitis media when the eustachian tube stops working. Oftentimes we see kids that they go and get sick, they get a cold flu, and then they get better, the fever goes away after a day or two, and then they get another fever on day 5 through 7. That is primarily eustachian tube dysfunction. All the congestion in the face is blocking that drainage, it backs up, and we get a brand new infection in one or both ears. So if we can teach parents this Galbraith technique and educate them that through myofunctional therapy, they can strengthen this and interrupt this process and prevent it from happening, that's less antibiotics for kids. That's less antibiotic resistant. That's less pediatrician visits. It's a win-win. Let's talk a little bit about temporomandibular disorder 2 here. Up to 33% of people in their lifetime will have an issue with TMD. Of course, the muscles of mastication are involved. The articular disc is really important to consider inside of the TMD joint. And then a lot of times what can happen is patients have these habits that go along and coincide with TMD, like clenching or grinding their teeth. And then their stress, the general tone of their nervous system and their cortisol levels really plays a role here too. We see a lot of sympathetic overdrive in TMD. And then this is very similar overlap. A third of patients with temporomandibular disorder also experience ear-related symptoms, hearing issues, tinnitus, all kinds of things. Now, you see this this picture here. We've just removed away the mandible and some of the zygomatic arch, so you can see all this complex anatomy underneath with muscles of mastication, nerves traversing through. Eustachian tube takes dives through all these very intricate muscles. So that's why there's so much overlap in this area. And Dr. Gill will talk about the embryology as well of this region, but that's why we see so much overlap in these disease states. At the highest estimate, about 85% of these TMD patients also experience tinnitus. So if we use myofunctional therapy to release these muscle spasms and retrain chewing and swallowing and breathing, and osteopathically treat the cranial strains, relieving and optimizing nervous system function, then together we can target the primary etiology of where this comes from. So that was the overall part 1 here, and I hope people are taking away how through osteopathy we can address a lot of structural and biomechanical dysfunction, tying into myofunctional therapy where we're retraining function. Osteopathy views structure and function as interchangeable and synergistic, and I think myofunctional therapy is very similar in that, and so that's why we would work together so well. Because we both come from this background where structure supports function and function supports structure.
Did we take questions or should we wait?
Let's wait. I have one more section and
absolutely.
Dr. Gill's gonna do some slides. If we can do questions at the end, that would be ideal.
Okay, perfect.
Thank you. Okay, so let's move on here. Little break. This is my family here. This is our family photo, an attempt at it. It's really hard to gather 3 dogs and get them to all smile. That's Moose at the bottom. He's the only one that's smiling, but that he's special. It's his special smile.
Oh my God, so sweet.
Okay, part two. So we're going to talk about a few things here. I really want to dive into sleep disorders and anxiety here, and why we should be the first referral from primary care or dentistry when it comes to those things. So I'll talk about malocclusion as well, but I'm also going to get into some of the evidence-based medicine. Everyone wants to hear what is the best evidence-based practice, what is the data and the science support. So I'll go into that so that you guys can cite these articles when you're talking to your patients. With malocclusion, we have temporal components, mandibular structures. I think people are familiar with that anatomy, and a normal range of opening, roughly 40 to 50 millimeters. We know that the muscles of mastication are heavily involved, but it's the coordination in all these muscles that is really essential. And I'm going to talk a little bit more about the actual nerves here. So this is a great picture that I'm going to come back to. But on this slide, you can see we've got a lot of overlap between two primary nerves in when it comes to a functional occlusion. The trigeminal nerve, which not only does a significant portion of the muscle drive, right? It drives the muscles of mastication, the mandibular branch of the trigeminal nerve, but it also gives proprioceptive feedback. Where is the jaw in space, which is essential. The facial nerve controls lip seal and tone and how the lips are involved in this actual process of swallowing and putting food in the mouth and breathing. But there's an integration that's happening here between these two cranial nerves, amongst others, that's very complicated. So if you have four cranial nerves, or two cranial nerves and two on each side, four pathways that have to be perfectly balanced, sending and receiving information, any kind of misalignment is kind of it's a self-perpetuating cycle, because the signals get lost and disintegrated. And Dr. Gill will talk more about this, but we do see functional retractions of cranial nerves in our work, where it's, you wouldn't see it on an MRI, but the way that the nerve is firing and functioning is as though it is not functioning within the jaw itself. So I wanted to give you guys an idea of how we talk about cranial strains in osteopathic medicine, and how that has to do with the face. So on the left side here, we have this child, top left corner. This is his normal photo, where he's got a head tilt to correct his cranial base strain and get his eyes level on the horizon. On the right photo of the child with the lines on it, the photo is actually corrected, so his head tilt is corrected, and so that you can appreciate how much asymmetry there is. And the ear is lower, the eyes are off center, one side of the face is wider than the other, and this leads to a crossbite. And on the right side, what you see is actually what's going on with the bones of the skull. We diagnose in our medical school training, we diagnose by strain patterns that happen at the junction of the sphenoid and the occiput. The SBS, we call it, the sphenobasillar synchondrosis. It's just a system for all of us to get on the same page, but this sets up a whole host of problems when you have a twisting and an opening on one side of the head and this major asymmetry, not just because of the misalignment of the teeth, the jaw, the face, and the tongue function, but I want to draw your attention to the bottom right skull photo. We're looking down into someone's skull from the top, and they're facing towards the top of the screen, essentially. And all the little holes in between the blue area and the white area, that's where a lot of these cranial nerves dive into. So you can imagine if there's any kind of twisting of that junction, cranial nerve pathways are being impinged upon. They're twisted. And this is a very important thing to think about when we're talking about how these signals are being integrated. It's not so much that you're going to see a complete palsy. It's not going to present like a stroke. It's not going to be, complete lack of function. It's going to be decreased function and swallowing dysfunction. So we have to address these cranial-based strains upon so that they can properly do this retraining. Okay, moving along here. Some of the techniques we learn to do include muscle energy, where the patients use some applied muscle resistance to lengthen spastic muscles. That's some people are familiar with MAT at a physical therapist's office. It's most similar to that muscle energy. We treat ligaments, we treat fascia, we treat organs, blood flow, nerve function, and Dr. Gill works heavily in the embryologic function and development. And through myofunctional therapy, we want to optimize the tongue function and position, lip competency, breathing benefits. So I propose a little sequence here where it's not so important whether the very first visit is either osteopathy or myofunctional therapy. That part is not the critical point here, but if we can work together in these beginning phases with the patients to address structural restrictions and enable them to actually fire these nerve pathways and then begin some basic exercises, the back and forth really starts to integrate our work where one supports the other, and we can get better results because the patients are maintaining their airway and their swallow because of the myofunctional therapy, and your offices get better results because they can actually send the signals and integrate the signals and coordinate the movements. So we have to kind of knock off the shackles, so to speak, before patients can really express the full capacity of their nervous system and swallowing and breathing and everything. And then I think we're on the same page here that we're both moving towards a maintenance. We don't need to see patients every 2 weeks after we've fixed most of their problems. We want them to come back similar to myofunctional therapists, once or twice a year, or if something goes downhill or they had a major surgery or, then yeah, come back for a little bit more. But we want to move towards this maintenance so people can go on about their lives. So in the interest of time, I'm going to move to just a summary here and some of the studies so that we can get to Dr. Gill's presentations. Just briefly on sleep disorders, we do see that, with osteopathy and treatment of the face, we can actually get measurable sleep study results and improvement where we have a better apnea hypopnea index, less O2 saturation drops, and less frequent arousals on a sleep study. So this is measurable. And then we also see statistically significant improvement in PCRIT values. You can think of PCRIT improvement as basically the resilience of the airway after this osteopathic treatment is much stronger. So it's going to shut down less. Now, this is just going into some of the different nerve pathways that are involved with sleep disorders. I'm happy to share my slides later if people would like to look deeper into some of these things and go into that. But I do want to move on so that we have enough time for questions at the end too. This was the study looking at the PCRIT values and resilience of the airway. So this was the SPG study in 2017. Essentially, they did a technique on 9 OSA patients and compared that to their later sleep study values, and it did show a statistically significant improvement in their airway resilience. So that's really exciting. So with osteopathic manipulation, we can enhance that pharyngeal and airway stability through that ganglion, the sphenopalatine ganglion that's coordinating all this movement. And through myofunctional therapy, we can maintain that airway patency. And then just briefly on anxiety, there's so many different inputs to anxiety, but there's actually no scientific, proof out there that anxiety is a deficiency in serotonin or norepinephrine. But those are the first line treatments. I guess behavioral therapy is first, and then most physicians will reach for the SSRIs and the SNRIs. But we have no scientific basis to prove that there is a deficiency in serotonin and norepinephrine. We do know that there's all these other inputs, including, the HPA axis, cortisol, stress hormone levels, how much is the patient in fight or flight versus rest and digest? Where's their tone at? So by working through this together from a oral facial standpoint with, reducing some of the clenching and bruxism, helping the facial muscles relax, and then osteopathically treating their gut-brain axis and relaxing their nervous system, we can get a lot of results. This was a study here also talking about moderate to severe anxiety. This was Dixon et al. in 2020 in the journal American Academy of Osteopathy, where they did a few osteopathic techniques on 26 adults and showed a 62% response rate, a statistically significant response rate in their anxiety scores. That's really good. Most antidepressants work on about 45% of patients, less than half. So to do an 8 to 9 week intervention, which by the way is the same amount of time it takes for an SSRI antidepressant to kick in, and get these kinds of results through osteopathic medicine, that's really great. And the remission rates are much better with osteopathic medicine than with SSRIs. So we can really address the autonomic and fascial and nervous system issues with osteopathy, and then through myofunctional therapy, we can maintain those muscle gains and those autonomic gains, and really work synergistically to help these patients keep their resilience. As you know, when you retrain someone to swallow and breathe correctly, generally they hold on to that. And that's one of the hardest parts about anxiety and depression and the relapse, is teaching people resilient skills that are going to keep them in the free and clear. Okay, so we went through a lot. There's a lot of anatomy. There's a lot of cranial nerves there, and that's why I'm happy to share my slides. I hope that people learned a few things about how osteopathy and myofunctional therapy can work together, and primarily how to be able to talk to patients about what it is that the osteopath does. So I will share these slides with you guys if you're interested, and without further ado, I'll hand you over to Dr. Gill. Thank you.
Thank you so much. I think you've presented so much organized collective thoughts. Fantastic. Okay, Dr. Gill, you are coming right in.
Good morning. I'm just delighted to be here with all of you. And I had no idea what a huge group this was from all over the world. So fantastic. Let's see. I just wanted to mention that I started working with myofunctional therapists over 30 years ago, and Dr. Nordstrom, who would come into our office and we would treat, and he would work on the appliances and teach us about the importance of working with a team. And I have to say, the time I spent with Barbara and Joy was very, very helpful to me. And there's a number of myofunctional therapists who refer into the practice, and it's a wonderful experience to have a conversation or a text or hear from them that they're working on a particular thing or they want me to work on a particular thing, because I think that team effort is so helpful to the patient, and the families feel really cared for in a deep way because we're also interested in helping them with whatever issue their child is dealing with or they're dealing with. So one of the great things I've experienced is being in the operating room with these pediodontists when they're doing frenectomies and other procedures. And it's helped me to learn even more about the different anatomical components and how pervasively they affect the body. So this is just an introduction to say, if we're seeing patients with oropharyngeal or respiratory or GI abnormalities, we have to really go to cause. And I think Dr. Hagopian did a beautiful job of explaining some of the anatomy that we can work on with cause. Let's do the next slide.
Dr. Gill, can you lower your screen just slightly? Because your name is covering your face on your window just a little bit.
Lower my screen like
So that you can, there,
this. That
perfect.
be
Thank you.
okay?
Yes.
Thank you for the technical. All right. So I wanted to just provide a few little thoughts and pearls to jog people's ideas of why to refer to an osteopath. When you do your histories on patients, I would love it if you would consider asking for birthing information, because individuals who've had a procedural delivery like forceps or vacuum, who have an odd presentation, meaning the shoulder is going into the birth canal, or their buttocks is going into the birth canal, or they're lying sideways, have a tremendous musculoskeletal and total body trauma that they have to overcome. And nuchal cord can also be a big issue in not only what happens with the circulatory system, but the cranium. And you can see torticollis secondary to nuchal cord. Let's move on to the next slide. This is what I call the Satipon twin. It's twin A. These are the babies that cry a lot. Their twin sibling is usually the Buddha baby, but they are the one who's screaming, moving, can't get comfortable because they're in a lot of pain. They had to grow against the resistance of another body in utero. And so if you find out that your patient was a twin, find out who was born first, because that can tell you a lot about the disorganization of their anatomy and their neurological system. Other children who really need our osteopathic support are those who have developmental delay. Genetic disorders can be benefited by osteopathic treatment. Not that we can cure the genetics, but we can help with some of the symptoms that they classically deal with and modify them and reduce them. Digestive dysfunction, tongue protrusion, plagiocephaly, trauma, concussion, temper tantrums, all these things really respond well to getting a structure function treatment with the osteopath. Basically, my opinion is every child should at least get one chance to see an osteopath. Next slide. So I wanted you to see what osteopathy can do. The picture on the right at 5:29 p.m. is this infant prior to being treated. And he had a history of difficulty nursing, a lot of gas. I hope you guys can all appreciate the upper lip tie facies in this baby and the tension in the mentalis muscle. He also has overlapping frontal bones, which make his head very narrow and forehead very narrow. And you can see that the right eye is closer to the screen and the left eye is posterior. The orbits are not even in size. So the first photograph was 5:29. The second photograph was 5:46 p.m. So roughly half an hour difference between these two pictures. And I'm hoping that what you can see is the frontals have actually spread and opened up, which means their fontanelle has gotten bigger, which is the soft spot in the vault. The eyes are more even. Oh, thank you. 17 minutes. I don't do math very well. The position of the zygomy and the midface is much more normal. You can also see that there's been an elongation of the nose. So one of the key points I'm going to want to hammer home is that lip frenum has an effect that goes all the way back to the fontanelle. And I learned a lot about this by working with dentists while they were doing frenectomies, but my passion is embryology, and you're looking at a tiny little embryo up at the top, and you can see that the two pieces that come together in the stomedium that are going to become the philtrum they're not, they're on either side of the midline. They have to come together. So understanding these developmental movements to form the face helps us to work in this way to help a patient change their entire structure. So this is an infant who absolutely would not touch a pacifier. And this is immediately after getting treated. And you can see he's really thinking about, wow, what am I able to do now? And I'm looking at how is his jaw moving? How are his lips moving? What's happening with his tongue when he's sucking? And then we'll go to the next little video clip. This is a few moments later, and I'm also looking at, is it different on the left and right side of the face? You can see more tension and tone in the lip muscles with this sucking. And you can see how hard they're concentrating because all sorts of data is coming in because all of a sudden their sensory nerves are telling them more information. That's fine. We can go on to the next slide. So this may be boilerplate for everybody, but I wanted to point it out again. I teach osteopaths about this. When we think about tongue function or dysfunction, which one of these infants looks to you like their tongue is in the right place when they're crying? Does anybody have a quick answer for me on the chat? No, I'm not getting a response, so I'm going to keep going. To me, the normal tongue function is, yes, the pale baby is correct, but the African American baby actually is where the tongue should go. When they cry, the tongue should lift up. And yes, the lower left, that's correct. So, and if you look carefully at that individual's tongue, it's more flaccid on the right-hand side, and there's more tonicity on the left-hand side, and there's also a deviation of the tongue. So you can see even early on, there's not a lot of coordination and information going to this brain to try and control the tongue. Let's go to the next slide. I wanted to bring up tongue tie, which has become such a challenging topic for all of us. When I was in medical school, it basically didn't exist, and now I see it all the time. When I did this talk in 2014, the incidence is as you see, and I Googled it for this talk, and now it's been reduced to 10% because of a redefinition of what tongue tie is, which is kind of fascinating to me. But fortunately, we have both osteopathic and dental and myofunctional approaches to dealing with tongue tie. And I'm always trying to tell my patients it's very important to see the myofunctional therapist because it's like expecting your body to run a marathon when you've never been to the gym if you don't know how to use your tongue because it's been tied down. I also wanted to just put a plug in for the posterior tongue tie that gets missed a lot. And that's really important in that rapid pull down of the tongue during nursing, which is supposed to vacuum the breast and help the mom make more milk. And all these moms who come in who say they don't make a lot of milk, it really has to do with the baby, not to do with the mom. So let's move on. I also wanted to mention positional tongue thrust in every age. This can be tongue tie mediated. This can also be mediated by neurological dysfunction. And if we miss abnormalities of tongue function, we can have negative contributions to mastication, digestion, respiratory issues, sleep apnea, anxiety, excessive body tension. And interestingly to us, it can really facilitate in a negative way scoliotic patterns in the entire body, not just the cranium. So let's move on. These are some children from my practice, which is why I'm asking, please don't copy these pictures, but I'm hoping you can appreciate this little girl in white, the tension of her Cupid doll face. And she actually had a number of frenulae that needed to be released in order for her to open up her mouth enough to get around the breast. The other infants in this picture have the lower lip tie and that retrognathic mandible, which I get sent a lot of patients for. And I'm very interested in anything myofunctional that can benefit these babies, because it's really difficult to change this anatomy and try and get them to bring the jaw forward in a more functional way. But I'd like to now move to some embryology, and then we're going to harken back to the frenums, and you'll understand why. So this is a 32-day human embryo, and I became fascinated in Dr. Blechschmidt and Gasser's embryology, which looked at the biokinetics and biodynamics of human development, which meant, why do parts move in different places? Why do we start with eyes on the side of our head and end up with eyes in the front of our head, kidneys in the top of our neck, and end up with having those down in our lower body? And one of my mentors, James Jealous, noticed that the kinetics and movements of facial development that these folks were studying under the microscope were very similar to the kinetics of healing that Dr. Sutherland, who invented cranial osteopathy, spoke of and taught. So Dr. Jealous's contribution is to look at the facial arches, and I want to mention the upper face fluid field, which you can see in this 32-day infant. I don't know, Dr. Hagopian, if you can actually move the cursor, or if I can move the cursor, but basically what you're seeing, the top of this, it looks like a head, that's all the nose in the embryo. And that black space, the stomedium, is becoming the future mouth, but just a portion of it. And the fluid field on the bottom, the mandibular fluid field, is what's going to contribute to our very important tongue and the lower jaw, and actually part of the zygomy and cheeks. The take-home point here is, from a developmental standpoint, the upper face fluid field that goes from that stomedium all the way back to the soft spot, it is in relationship to every single part from here to here. And that means the brain, that means cranial nerves, that means bones, it means everything. So from a developmental, functional, and osteopathic standpoint, it is part of one of the important developmental fields that we need to know about, from that anterior fontanelle to the premaxilla, and that's the previous slide. And it affects the development of the midline. So that frenum that we wrestle with in the upper lip affects the development of the mid face from the fontanelle to the upper lip. So it's very important to me that you encourage dentists, if they're going to do a frenectomy, to separate the frenectomies. And I know that means pain for a couple of days for newborns, but even if it's a 24-hour difference for a newborn, you're respecting developmental relationships and functions by releasing the lip and waiting a day before you release the tongue. It makes a huge difference in cranial function and development. Okay, let's move on to the next slide. Next slide, please, Dr. Hagopian. Thank you. This is looking at the human face. And, pardon me?
Don't worry, I think there's someone just on internet.
Okay. This is looking at the human face, and we're particularly interested in the orange area. That's the mandibular fluid field. And what we've learned in biodynamic osteopathic research and embryologic research is that field actually extends all the way posterior to the back of the skull, and includes the brainstem, etc. So it's a completely different system. And when we do a tongue release, we're working with that particular system. Okay, let's go on. So here's another plug for looking at all the reasons why you might consider doing a frenectomy in certain patients. The upper CT scan is of a child who is before their lip tie is released, and it shows you how bowed the roots of the central incisors are due to that, the teeth having to develop within the constraints of that upper lip frenum. And this slide was generously donated by Dr. Sammy. And when the frenectomy is done, if you look in the lower images, you can see that the roots actually come into alignment into a much more appropriate fashion after the frenectomy. This is not every child, but it's something to consider in the back of our minds as we assess, can this baby breastfeed? What's happening with speaking? Is there so much tension in the lip that they're not really swallowing functionally? All right, let's move on. These are some other little pearls for you. So I like this diagram. It's showing you a child who's awake, and the purple is showing the airway of the child, and they're upright. And that's an A is a normal awake child with functioning airway and tongue position. B is a child who has some slack in the tongue and open mouth breathing, and you can see what happens to the airway and how it collapses. C is that same child trying to sleep. D is that child using their health intelligence to solve the problem with the thumb. I never thought of thumb sucking as a problem solver, but in fact, what's happening is as that thumb is sucking, they're opening their airways so that they can breathe effectively. And furthermore, the little cozy maneuver that a lot of kids do rhythmically on their nose when they're sucking is facilitating primary respiration, which is the cranial rhythmic index. We talk about the midline bones in the skull will flex and extend 8 to 10 times a minute, and the paired bones will externally and internally rotate 8 to 10 times in a minute. But this is just information. It's telling you that there's an intelligence in there that's working to solve the problem. Of course, we want to get them to stop sucking their thumbs, but that's why I count on you guys. I also tried treating the sucked on thumb because I've found that there's nervous system abnormalities all the way to the thumb. Let's move on to the next slide. So on the right, this is an infant who's having a lot of disorganization with nursing, and she's really not figuring it out. She's kind of moving her head all over the place. There's not a lot of coordination. She pulls off the nipple a bunch of times, and the mom complained that this is what happens when she is trying to eat. And she gets some good sucks in, but then she can't figure out how it happened. It's like a miracle that worked for a few minutes, but I don't know why. That's what's happening in their brain. So now let's move to the second video. And this is her immediately after getting treated. And you can see how alert she is. That's that thinking brain. Wow, I'm getting information about my mouth and my tongue all of a sudden that I didn't have before. And this is me trying to evert those lips so she can get a better seal. But even though she's not super hungry, you can see she is not letting go of that nipple. She is going to work on this and stay present. And I hope that provides some more information about what we can address when we work on cranial structural abnormalities, neurological dysfunctions. It's so important to me that babies get a chance to nurse if they can. And I want to be participatory for that. All of us do as osteopaths. And we want to work with you with whatever you've discovered to help newborns. And I know I've texted some of you and asked for help with some of these really tough cases. Let's look at the next slide. So this is, back, there's that original picture that I showed you of the 32-day embryo in black and white. And we're looking at the development of the human tongue. And this image with the colors, green, yellow, blue, and red, basically the fetal head is folded over and flexed forward, and we've cut through the head this way. I don't know if you guys can appreciate that. But what I want to point out is the tongue itself develops from 4 metabolically active fluid fields. So all these processes are happening in these 4 different fields. They're all related to different cranial nerve function and different components of the oropharynx. And this is a Dr. Gill personal theory, not a proven fact, but I believe that the different types of tongue ties that we see actually can be attributed to their relationship in a dysfunction in one of these 4 fluid fields. And particularly the posterior tongue ties, I think, have to do with when the overlap happens developmentally with the yellow portion overlapping the blue portion in the tongue. I'd love to see some research on this. I'd love to know what anybody in your group knows about it, but I'm trying to figure out how to work with it because I think that sometimes we can really significantly change anatomy without doing surgery. And that's what I know myofunctional therapy can do as well. So let's move on to another slide. When I was first taught cranial osteopathy, we were told to look at the condylar parts. So this is a newborn occiput, and it's in its pieces. And you can see the blue there, that's cartilage. And the green arrow is pointing to the condylar parts. The condylar parts rest on the upper cervicals, on the first cervical vertebrae. And those parts are in a lot of pieces. So you can imagine as that baby's corkscrewing down the birth canal, you could get a rotation of the area that says 5 and 4. Those condylar parts could be like skis. They could be in a pizza. They could be in a parallel turn. They could be one higher than the other. And that distorts the anatomy. I was taught in order to help the hypoglossal or 12th cranial nerve, what we had to do was address the condylar parts. And what I learned over time is I can't just do a technique, spreading the parts and pulling, because that actually can affect the bony structure and the dural structure and vascular structure in a negative way. And now what I'm super interested in is how do I get the very most distal branches of the hypoglossal nerve to start stimulating the different musculature of the tongue so we can actually have a baby who will go from not touching a pacifier to sucking on it right after a treatment. And I've realized I'm kind of out of time and you guys really need a chance to ask questions.
Oh my goodness. Well, you've ignited so many areas of discussion, and I know we don't have that much time.
So let's let you guys talk.
Yeah. Well, how about this? I know, first of all, next week we're going to have a tongue tie release provider who's been doing this for over 20 years, Eyal Boetzer, with our Klatsch. And I really want to help bring in the discussion around lip tie and what's happening. And you really teed it up in a way that is so fascinating in terms of understanding these connections, because I think we lose the translation and what you described in terms of one procedure and allowing this integration to take place before the next procedure. That is something that I haven't heard as kind of a standard. And I would love to hear what you see, what's integrating, and just even 24 hours, how is that helping?
This is years of ahas for me, but the biggest aha was being in the operatory with Dr. Sammy with a baby with a grade 4 lip tie. And as she started to release the lip tie, I got to feel the opportunity to completely open a very, very tight fontanelle. And that's what allowed me to understand, oh my goodness, these are connected. And then I went back to look at the embryology to understand that better. But it's kind of like a rubber band. If you release this lip tie and the tongue tie at the same time, everything contracts together. So there's huge tension that gets created in the dural system, in the cranial base, in the oropharynx, and it's harder to undo that. So if you just give 24 hours and release the lip first, then all the changes that can happen in the upper face fluid field from that fontanelle all the way to here can occur, and they're ready, set to have the release posteriorly with the tongue. And I know people are worried about pain, and yes, it is painful, and we do recommend treatment and homeopathy and other things to help babies. But generally, I've seen if they just have the lip done, it's the first 6 hours or something, and then they're okay.
Thank you.
Old children, it's not as big a deal. Newborns, it's a really big deal.
Okay, I see.
I love this talk. So osteopath for me has helped so much for my patients. I'm a physical therapist that does a lot of craniofacial, TMJ, tinnitus, all that you've mentioned. And we have an osteopath that works with us and an osteopathic PT that works with us. one thing I wanted to mention was the I loved what you mentioned about the lip tie. I'm excited to hear more about that because I didn't realize how much tension that would affect the teeth position. But the thumb sucking. So thumb sucking, it's interesting to hear that the thumb sucking opens up the airway. So that suction is what actually creates a more stable airway for these infants, even regardless of whatever they're dealing with in their airway. They create a suction and pull that airway kind of nice and tight. I'm in the belief that osteopaths, PTs, like PTs are a part of the team because they work on posture in general. You know, overall posture, I think, is affected by all of the airway dysfunction. So airway kind of causes a lot of things to happen: the clenching, the thrusting, the cranial bone changes, the neck changes, but and the rib cage changes. Everything changes. So the ribs, if the ribs and the rib cage are in a position where they're always going to be breathing fast, rapid through their mouth and high, I think as just an adjunct to making a team, it's important to work with a pediatric PT, someone that understands children and adults, to better align all of these structures depending on, you know, the muscle activation that occurs when they're dysfunctionally breathing. And that happens, as you know, all of you are aware of this. It happens all day, sometimes 60,000 times a day when it's supposed to be 30,000 times a day. So I wanted just to mention that I love that osteopaths are working with myofunctional therapists. I think that's critical. And I think that the osteopaths should also understand what PTs bring to that picture too. And I think that's what I try to just keep everybody aware of, that there's a bigger team. There's a bigger team of hands-on providers that can help really restore the alignment and the function of the child and the adult. So thank you so much for this lecture. It was amazing.
Agreed. I definitely think the interdisciplinary component, it runs wide. And thank you for that PT layer of what mechanics and function are doing. I know we're out of time. This is sad. It's a sad moment. No, but I just want to say, people are here because I think osteopathy gets lost in translation, and I really appreciate the mechanical understanding. And you did mention many things. Obviously, you know, Michael, Dr. Hagopian, what you brought in with regard to sleep disordered breathing, PCRIT, the understanding around osteopathy, anxiety, myofunctional therapy, obviously breathing, and the sphenopalatine ganglion and how that supports airway patency. That is so fascinating. I mean, there's so many layers of what you brought into this arena that I would love to explore further. And I know other people want to as well. We might have to have you come in for session 3 and 4 if you're willing.
Sure. Yeah, I'd be happy to.
Yeah, I
Let
really
us know.
And yes, the slides in terms of references of studies, I mean, I think we're all on the front lines trying to share why what we do has a place in the medical arena. And that's how myofunctional therapy really was brought in through research starting in 2009 with Katia Guimaraes and the oropharyngeal exercises, and then the 2015 meta-analyses. And sleep is really why we are in this medical arena and more than a functional perspective. So your insights with what you brought in is so helpful. I want us to get the slides, and I do put them into our Myo Coffee Klatsch archive, just so that people have references that they know that they can share, because that's really what it comes down to. And I think it's really important. Both of you, I just want to say to this group, Doctors Gill and Hagopian are in Santa Monica. Dr. Gill, you've been practicing over 30 years. And the focus with babies and embryology is so helpful. And you did mention that tongue ties are increasing. Is that what you see in a?
I do see more tongue ties, and I wonder about what the etiology of that is. I don't know, but there's something pervasive that's causing a developmental arrest in the entire oropharyngeal complex. Because as Dr. Hagopian hinted, the neurological system is developmentally delayed. The tongue position is abnormal. The way the face is made is abnormal. And, you know, I'm seeing more and more and more of this with children and just wondering what to do. You did see on one of those images that, you know, we can change the midface to an extent without doing the frenectomy. So I've kind of come, I used to really just want everybody to have a frenectomy. And now I'm kind of more in the middle of the road that, you know, there's lots of people who don't need it. So how can we work around it?
Interesting.
But
Well, yeah, I think what you see clinically on the front lines is such an asset. I know Barbara and Joy Moeller have described this, having done myofunctional therapy for 45, 50 years. There's an increase and we don't really know the etiology. We can't be clear. Okay, I think we have to close for today. But if there's a chance for you to come back, I know you would just be utterly welcomed back because I know there's more questions. And I just want to say again, thank you so much for doing what you're doing. I mean, this is when you talk about these early interventions, I mean, this is really incredible that you can really shape the trajectory of health. And then as these conditions develop and advance, where you can step in at different stages of life and over the life spectrum. And so I really want to share that this and osteopathy obviously can come in at any stage. But it's so interesting to look at the function from an embryologic perspective. And what you shared was absolutely fascinating.
I just wanted to say, Samantha, because we kind of cut off the opportunity for asking questions, if I don't know if there's a way for people to send a series of questions, just in one document, you know, just one time.
No, I will collect it. I will collect it.
Send it to us.
We
can, you know, maybe address them and then send you back what, you know, simple answers we have.
Okay. I'll organize it with everybody.
Okay.
I'll try not to make this a lot more work for you. That's what I don't want. But I know that people's questions do need to be answered and that your generosity in having that opportunity is really appreciated. All right, everybody. Thank you so much. You can unmute yourself if you want to say thank you. Thank you, thank you, thank you. Everyone is so grateful. This was such a wonderful kickoff. Thank you again.
Thank you very much.
Yes, absolutely. Thank you so much.